Ladies and gentlemen, thank you for standing by. Welcome to the Celebrating Partnerships and Progress, the first year of the National Prevention Strategy webinar. During the presentation, all participants will be in a listen-only mode. If you would like to ask a question during the presentation, please use the chat feature located in the lower left corner of your screen. If you need to reach an operator at any time, please press *0. As a reminder, this conference is being recorded Wednesday, July 18th, 2012. I will now turn the conference over to Leslie Erdelak with the Association of the State Territorial Health Officials. Please go ahead.
Good afternoon, and thank you for joining us. On behalf of the Association of State and Territorial Health Officials and the National Association of County and City Health Officials, we're pleased to host today's webinar, which celebrates the first year of the National Prevention Strategy in action. You'll soon hear from each of our esteemed presenters who've been part of generating momentum for the strategy and reinforcing its principles across every sector of government in states and in communities in the U.S. Moving prevention forward by addressing the health impact of all policies is a charge and a challenge that state and local health agencies, together with their many partners, have readily accepted. Join us for the next 90 minutes to hear how this call to action is driving progress and innovation and creating a sustainable path to better health and wellness. In just a moment, we'll hear from our first guest. But before we begin, I want to remind you of a few important items. We're set to hear from 4 dynamic speakers today. I'll introduce each of them individually, and at the conclusion of all of the presentations, you'll have an opportunity to have your questions answered. You can submit questions at any time during the webinar by using the chat feature located on your ReadyTalk panel. We'll be recording today's session, and the archived recording will be available on both the ASTHO and NACCHO websites. Of course, you can also follow us live on ASTHO's Twitter feed. And finally, we'll be sending you a link to a brief survey. We'd appreciate your feedback on today's webinar, so please take a few minutes to send us your thoughts. And now I'd like to introduce our first guest, Dr. Regina Benjamin. She's the 18th Surgeon General of the United States. As America's doctor, she provides the public with the best scientific information available on how to improve their health and the health of the nation. Dr. Benjamin serves as Chair of the National Prevention, Health Promotion, and Public Health Council. The National Prevention Council comprises 17 federal departments, agencies, and offices. The Council provides coordination and leadership at the federal level and identifies ways that agencies can work together individually as well as together to improve our nation's health. Welcome, Dr. Benjamin, and thank you for being here with us today.
Thank you, and good afternoon. And thank you to the Association of State and Territorial Health Officials, as well as the National Association of County and Health Officials, for sponsoring this webinar today and for helping us celebrate the first year anniversary of the National Prevention Strategy. As many of you have often heard me say, health does not occur in the doctor's office and the hospitals only. Health also occurs where we live, where we learn, where we work, where we play, and where we pray. I'm a longtime champion of the power of prevention, and it's the foundation of my work as Surgeon General. I believe that prevention offers the greatest opportunity to improve the health of America's families now and for decades to come. I also believe that prevention is the key to building a stronger and more sustainable healthcare system. Prevention is not new to the national dialogue. However, in recent years, it's become more vital and more relevant than ever before. It's become an imperative. And that's largely due to the changing dynamics and the demographics as more American families struggle to deal with chronic illnesses such as diabetes and hypertension and emphysema, and the tragic toll that they take, both personally and financially. Preventing chronic illness has a profound and measurable effect on our communities and our economy, impacting people of all ages, ethnicities, and economic strata. Almost 50% of adults have at least one chronic condition. Just 4 modifiable health risk behaviors: 1, the lack of physical activity; poor nutrition; tobacco use; and excessive alcohol consumption. Just those 4 things are responsible for much of the illness and the early death related to chronic diseases. We have to make prevention part of our everyday lives and empower people to make better health choices. The Obama administration has launched a broad agenda to help Americans get healthy, live longer, stay well, and thrive. As Surgeon General, I have the privilege of chairing the National Prevention, Health Promotion, and Public Health Council that was established by the Affordable Care Act, the health reform law. This council consists of 17 cabinet-level heads of federal agencies such as the Department of Transportation, Agriculture, Department of Labor, Environmental Protection Agency, Department of Defense, HUD, and others. And there's also a presidentially appointed advisory group of outside experts that advise our council. Next slide. Last summer, the council released the first ever national prevention strategy. Our vision is to move our healthcare system from a focus on sickness and disease to a focus on wellness and prevention. So in addition to the state-of-the-art medicine, we need a new approach to promoting prevention in our communities, since staying healthy depends on other factors that influence our health, like housing, transportation, education, the availability of quality, affordable food, our workplaces, and our environment. Next slide. The goal of the National Prevention Strategy is to increase the number of Americans who are healthy at every stage of life. We have 4 pillars: healthy and safe communities, clinical and preventive services, empowered people, elimination of health disparities are the 4 pillars. And we have 7 more focus areas, as you see around this wheel, such as tobacco-free living, active living, healthy eating, sexual and reproductive health, and others. If we follow the recommendations of the National Prevention Strategy, we can prevent or at least significantly reduce the 5 leading causes of death. And those are heart disease, stroke, chronic lung disease, cancer, and unintentional injuries. Each year, we present to President Obama and to Congress a status report on the National Prevention Council. This year, we released the report about 4 weeks ago. We also added to this year's report a National Prevention Council action plan. We didn't want the National Prevention Strategy to be just another great document that sits on a shelf. We want it to come alive, to be a living document. So the action plan document is the National Prevention Strategy's action and what we're doing from the federal perspective. The action plan compiles and highlights about 200 specific prevention and wellness efforts that are already underway by the government. It includes 2 things. It highlights the efforts and to the extent which the various federal government departments have already been working together on prevention, and the things that they're already doing in the area of prevention, such as the Department of Transportation has this Safe Routes to School where kids can get to school easily together. One of the parts of that Safe Routes to School is the walking school bus that many of you may have heard of. The parents will pick up the kids, walk them to school, and pick them up in the evening and walk them back home. And the Department of Transportation has a grant to promote that and make it safe for that. USDA has My Plate. Housing and Urban Development has the smoke-free multi-unit housing authorities. And we have the National Drug Control Strategy. All these are prevention efforts that are being done in the various departments, and there are many more. The other thing that this action plan highlights is it shows how these 17 government departments are starting to work together across departments with each other on various initiatives. For example, we have the Million Hearts campaign. That's various agencies working together to try to prevent 1 million heart attacks in the next 5 years. We have the Veterans Transportation and Community Living Grant Program. We also have a Green Garden Schools that involves healthy foods, environmental impact, and increased activity in schools. We have the Let's Move program, Let's Move Indian Country, Let's Move DOD Nutrition. These are all showing how these agencies are working together. There's also the National Forum on Youth Violence Prevention. That includes the Department of Justice, Education, Health and Human Services, HUD, Labor, and the Office of ONDCP working together to build a capacity to reduce and prevent youth violence. And the future actions of the action plan is basically we want each member of the department to commit to do three things. And this year, all three things they've committed to. Each of the 17 agencies committed to working towards tobacco-free environments throughout their departments and with their with the people that they work with as well. The second thing they've committed to do is to increase access to healthy, affordable foods. And the third thing is to put health and a health lens on all of their activities. So identifying increased opportunities for prevention. They're all encouraging their partners to do the same thing. So we see the National Prevention Strategy as a roadmap to health and wellness for the nation. And we see the action plan as showing some of the paths that the federal government is taking to get us there. We're attempting to lead by example, and some of the action plan of our examples and our National Prevention Council members and their public commitments to health and wellness. To truly make this National Prevention Strategy come to life, the federal government can't do it alone. We need strong leaders like you who recognize that partnerships are needed to achieve this, and a concerted effort from policymakers and health professionals, state and local governments, insurers, businesses, and community leaders, advocacy organizations, consumer groups, faith community, and individuals. Next slide. One of the things that we noticed is we've been doing a number of regional meetings around the country, and we like to thank the health departments in both state, local, and county and city health departments who've helped us put these regional meetings together. And in each of those regional meetings, we've done walks and activities and fun things. We want to make being healthy fun. It has to be a part of everything, our everyday lives. So the next slide shows that we did a Zumba on the plaza and the walking at one of our meetings in Boston. We were out walking. Unfortunately, I can't see the slides anymore, so hopefully those are there. Some of the other things we're doing is things that affect communities and individuals. We had a youth tobacco report that recently went out, and that tobacco report focusing on youth and young adults. Every single day, 1,200 Americans die of cigarette smoking. Each one of those young people, each one of those deaths is being replaced by 2 young smokers. And 90% of all smokers start before the age of 18 and 99% before the age of 26. So we want to try to keep our next generation tobacco-free by preventing them from taking their first cigarette before age 26. And we're launching an initiative around this with universities and to make the university campuses smoke-free. So we'll be reaching out to many of you to help us with that in the universities and college campuses in your communities. You can follow us on Twitter, which I think is the next slide, at SGRegina, and that will kind of keep you involved, knowing what's going on with many of the things we're doing. But basically, becoming a more healthy and fit nation requires more than just educating the public or creating programs piecemeal. It really requires a unified plan of action like the National Prevention Strategy, and it requires a group of leaders just like you to lead that charge. And so I want to encourage you and ask you to lead that charge. And so to learn more about the National Prevention Council, the National Prevention Strategy, and the action plan, and what you can do to help with the prevention as we go forward is in the next slide. I look forward to continuing working with you and on this and many more important public health issues. So now I'm going to turn it back over to Leslie.
Thank you, Dr. Benjamin. It's really great to see so much enthusiasm and support across the federal agencies. Next up, we'll be hearing from Betsy Pandora. Betsy Pandora is the coordinator of the Columbus Public Health Healthy Places program. She also manages Columbus Art Walks, a 2012 NACCHO Model Practice Award-winning program where she's excelled at engaging neighborhoods in walking and art development initiatives. Ms. Pandora holds a Bachelor of Arts and Master of City and Regional Planning degree, making her one of only a handful of trained urban planners working in a local health organization nationally. She's an expert on how land use decisions and built environment design can be used to foster healthy and active communities. Ms. Pandora, you may begin.
Thank you so much for that very nice introduction, and I am very excited to join all of you today and to be presented with such talented and inspiring panelists and speakers. Thank you to NACCHO and ASTHO for inviting me to present. I was asked to share information about my work at the local level on prevention in the built environment, specifically in the realm of healthy community design and active living. I've been asked to share some lessons learned for practitioners on how to implement a similar program as mine, to discuss issues you may face in doing so, and to talk about how the National Prevention Strategy has really been helpful in the implementation of a program like this. I know time is limited, so I'll move through these slides at a pretty good clip. So without further ado, we'll talk about healthy community design review. And you've already advanced to the next slide. Thanks. So first I want to talk a little bit about the overarching program that I run called Healthy Places. Healthy Places was created in Columbus, Ohio by our Health Commissioner, Dr. Teresa Long, in 2006 in response to a mounting body of research that shows that place really matters to your health. And specifically, like the image on the slide shows, that where you live and how individuals choose to get around to daily destinations can have a profound impact on rates of obesity and on other chronic diseases. My program is staffed by an urban planner, not a traditional public health person, but an urban planner working on place-based interventions inside a local health department to impact rates of chronic disease in our community. At the time that the program was created, Healthy Places really was only one of a few that had the staffing structure, and so today more and more I'm meeting planners around the country who are either working in or who are working in very deep partnership with public health agencies. So I can't attest to how truly novel I am anymore, but it certainly is a special program. The mission of the Healthy Places program is to promote development policies and practices that reduce negative health impacts and to create places that foster physical activity in daily life. So we do this specifically by focusing on the built environment and its design, on community design that supports active living and connectivity and active transportation, on development policies and practices that encourage land uses that support active living, and really on fostering places for daily physical activity, changing the culture and perception of how we should be getting around and how we should be leading an active life in our communities. Next slide, please. So, how did we get started doing this work? Well, we started by asking the question, how can public health change the built environment so that we have places that look like this image here, which is an image of Columbus's first complete street in our downtown. We actually hired as a consultant our newly retiring city planning administrator to come into the health department and consult and figure out how to build a public health-based program around answers to this question. How can the public health department really engage in changing the built environment? Next slide, please. So we really identified through this deep consultancy 4 ways in which our public health department could really make an intervention to change the built environment to support health. The first of which is collaborating in the land use change process. And I know that we found very helpful a lot of information that NACCHO in particular had put out there on land use planning and fact sheets, and really spelling out the various ideas and concepts and language that urban planners speak and public health professionals speak, and really how they're the same language. We could collaborate in the roadway development process. What better way to encourage active transportation than on our roads? So that's another idea. We could incentivize private development so that private developers wholly embrace active living and community design that supports that. And we could really work to change culture, so we could do education both to our private developers but also to our residents so that they understand the true value and importance of all of this. We actually developed a whole process around the first bullet, and I'll spend the next few slides discussing that. But in developing our program, it became very clear to us that we needed to have someone who had unique expertise in these various community development processes. So a trained urban planner was hired into the health department to really spearhead and create the program. Next slide, please. So we created a public health intervention called Community Design Review. And this is actually an intervention in our city's rezoning process, which is one of the primary ways which land use change occurs in our community. Zoning is land use. It determines how a property owner can use their land, and it plays a major role in shaping how things that are built must be designed on that land. A rezoning happens when someone desires a new use in the development or redevelopment of their property. So we launched our engagement in this existing process in 2007. To launch our engagement, Public Health simply asked for a partnership with our then Department of Development and our now Department of Building and Zoning Services to become a staff reviewer of all rezoning and council variance filings in our city. In this capacity, the Healthy Places program makes educational recommendations, not requirements, on a monthly basis to encourage private developers to voluntarily go above and beyond our zoning and building code requirements to strengthen their projects for health by increasing active living features. So the graphic on your screen there kind of quickly shows how this process works. A developer files some paperwork for a rezoning. Healthy Places, the program then reviews that paperwork. Either it's a site plan or it's development text, which spells out exactly how things will be designed and built on a site. And we make comments to increase active living features. Those comments are given to the developer, and the developer has the choice to either accept them or reject them. The next step in the process is that the rezoning application goes before our Development Commission, which is an appointed group of experts in land use in our community who makes recommendations on whether a property should or should not be rezoned. If the developer did not accept Healthy Places recommendations, we actually sort of make an appeal to our Development Commission in the form of an attachment that gets submitted with the application. And it says that the developer hasn't accepted our comments. You should consider that as you consider this rezoning. If they do accept our comments, however, Healthy Places writes a whereas statement recognizing the positive health impacts being brought to our community by this project. And this whereas statement is really important because it actually gets put into the ordinance and the legislation that gets created for the rezoning. So the developer is then required, by merit of their voluntary commitment, to do what they said they would do. It then goes on to our city council, and depending on whether the zoning is approved or not, it becomes a form of built environment change to support active living or a form of advocacy to support active living. Next slide, please. So, what does Healthy Places ask for in this process? We ask for things that are shown in the images here on the slide, such as increased pedestrian amenities, like better landscaping, seating, wider than code-required sidewalks, street trees, buffers between the streets and the sidewalk, and bike racks, which actually are now required in the City of Columbus's zoning code, and I'll talk about that a little bit more. We ask for connections to adjacent uses and parcels so that a developer is being thoughtful about the parcels that are around them and how they can provide an active form of transportation to other uses. We ask for pedestrian paths from the street to the front door of buildings, for safe pedestrian means through a parking lot. We ask for signage and pavement changes and nice brick and texturing to show where pedestrians are relative to other automobiles. And this just sort of represents the minimum standard of things that we ask for. We actually have some more intense requests that we make depending on the type of development. Next slide, please. So this has been an incredibly successful process for us. From 2007 to 2011, 55% of all of Healthy Places comments have been voluntarily accepted by private developers. It actually had steadily been 65+%, but until the last year when we took a dip, in part because we actually rewrote our parking code to include active living features in 2009. In 2009, our parking code was rewritten to include a bike rack requirement and a pedestrian connection from a public street to the front door requirement. And the thing that was so special about this rewrite is that the Healthy Places program actually played a role in setting a precedent for why we should require that of developers, because so many developers were open to accepting that voluntary recommendation that we had been making. The Community Design Review process actually won a NACCHO Model Practice Award in 2010. So you can go on NACCHO's website and get detailed information about the process and its outcomes as of 2010. And it's actually a process that NACCHO recommends that other cities and municipalities look at implementing. Finally, we started to see something really exciting in 2011. We had that parking code change in 2009 that really kicked into effect in 2010, so we had started to see bike racks automatically coming in, but 26% of all rezoning applications actually started to include active living features beyond bike racks. So we started to see this kind of culture change towards prevention, and that developers were getting it. They were getting that these were things that the public wanted, and these were things that really did support a healthy and active lifestyle. Next slide, please. So here's a quick summary of some observations that we've had in the implementation of this program and kind of what it takes to start implementing it. In many cities, you may find, as we did here, that the political will really is the first piece. And we have the political will in this country for a national prevention strategy. At a local level, it takes political will to advance prevention forward as well. And so it really took a vision from our health commissioner to get this program established, and taking the leadership like groups like NACCHO and the American Planning Association and reinforcing why it's important as well. There's no formal policy for this program, and the reason for that is because in our community in particular, putting an increase in development requirements on developers can be a bit of a hot-button issue. Columbus is a growing community. We're actually one of the only places in our state where we have real and intense amounts of development happening, and we don't want to impede that necessarily through increased regulation. So what we've done is position this program as something that is really rewarding for developers to do. They get a great piece of legislation that says why their program is doing so good things for health and prevention. So that we found that to be really effective. It really requires a diverse set of public and private stakeholders to make this work. Collaboration and communication among multiple agencies is important in getting multiple agencies to support that the health department is asking for these things and encourage that developers do them. And then in terms of what's needed to make the program work, it's a fairly easy program to implement. The workforce capacity needed really is the specialized expertise of an urban planner. The resources for us that were needed were few because we picked an existing process like our rezoning review process. So there was already a system in place. We didn't have to invest in creating a method for people to participate in it. It was already something that existed. The funding that was needed was for one staff person, their general funds for a full-time staff member to make this a component of their work. In other communities that I've talked with, funding for a full-time staff person really is an issue, and so something that I've often suggested is reaching out to another agency, your planning agency, your public service, public works department, and see if you can get a percentage of one of their planners or their engineers' time put towards working on health interventions in the built environment. Next slide, please. So a couple lessons learned in practice. Like I said, it really does start with inspired leadership. Getting your mayor, getting your health commissioner to speak on behalf of prevention and why that's so important has been really key. Collaboration is key. My program really only functions through good relationships with the folks who are truly the real experts in the implementation of design and development of the built environment. So engineers, safety officials, development professionals, they're key in terms of collaboration. And you may need to be prepared to educate and evangelize a little bit before you get started. Public health people and even planning people, we get it. We get why the built environment is important. But you may need to do some work to fully get that message understood by folks who aren't within our field, who don't necessarily have the training and background that public health folks do. And I think the biggest thing is don't be afraid to ask to be invited to the table. Start by engaging in a planning process or engage in how a road is being developed or built in your community and see if there's a way that you can get a decision made in favor of health and prevention. And if you're really truly interested in learning a lot more about this process, there's an academic article that was published in Public Health Reports. I'm happy to make copies of that available electronically to folks after the presentation, called Promoting Active Transportation as a Partnership Between Urban Planning and Public Health. Next slide. So in closing, I think we've been really fortunate here in Columbus to have a Healthy Places program for the last 5 years, but the National Prevention Strategy really has done a lot for us in terms of advancing our work. It really outlines how agencies should be working together in a health and all policies approach, and it's really laid the groundwork for multi-agency partnerships, and it's even helped to establish some models for how funding sources should be allocated contingent upon a multi-sector, multi-agency approach. So I think that's been very important. And it's really set the stage for walking the walk. The federal government's walking the walk in terms of partnerships and collaboration and embedding prevention into the work of multiple agencies, and that's been really helpful. Further, I think it's helped to normalize some very traditional public health projects or processes that are just really key in terms of advancing work on health in the built environment and prevention. I hear other folks beyond the public health people in our city government now talk about health impact assessments, health in all policies, and particularly how an evidence-based practice or approach should be used or employed in how we're making a decision about something. And that a couple years ago wasn't necessarily something that I was hearing the everyday engineer say. So I think that, at a national level, it's been really important work that's being done, and we're glad to play a part and a role in it at the local level. You can go to the next slide. Anyone's welcome to follow up with me and contact me about our program and our project, and I really appreciate being invited to join all of you today, and I will be happy to take questions at the end.
Great. Thank you, Betsy, for those excellent insights. I'm sure many of us can relate to those lessons learned. Our third speaker today is Dr. Laura Gerald. She is the State Health Director of the North Carolina Division of Public Health. She has served in several other key health positions within state government. She was the Senior Advisor to the Secretary of Health and Human Services and has also served as the Executive Director of the North Carolina Health and Wellness Trust Fund Commission. Dr. Gerald is a pediatrician who also provided clinical coverage at the Children's Health of Carolina. She's a member of the North Carolina Pediatric Society, the North Carolina Medical Society, the American Public Health Association, and she's a fellow in the American Academy of Pediatrics. Dr. Gerald, take it away.
Thank you, Leslie, for that introduction. And of course, I will also add my thanks to NACCHO and ASTHO for the invitation to participate in this webinar this afternoon. It's certainly a pleasure and an honor to do so. And I am looking forward to sharing some of our efforts that we've undergone here in the North Carolina Division of Public Health to collaborate with our state's Department of Transportation. I hope that our description of how this perhaps somewhat unconventional partnership has developed will help you as you consider ways that you can act upon the national prevention strategy. I also want to recognize and thank Dr. Ruth Peterson and her staff here at the division. She is our section chief for chronic disease and injury prevention, and I'm largely reporting on the work of that section. Next slide, please. And go on, moving quickly. Next slide. I'll take just a few minutes really to preach to the choir and put our activities here in North Carolina in the context of the National Prevention Strategy. Of course, Dr. Benjamin has already described the goals of this strategy, and I'll just echo and reiterate some aspects that are really resonating here in our state. We know that preventing disease and injuries is key to improving America's health, and when we invest in prevention, the benefits are broadly shared. Children who grow up in healthy communities and homes and families are more likely to become productive and healthy adults. And businesses benefit because a healthier workforce reduces long-term health care costs and increases stability and productivity. And furthermore, communities that offer a healthy, productive, stable workforce can be more attractive places for families to live and for businesses to locate. Next slide. This has become a very well-known slide, but I'll say when we want to improve health, we often can get very focused on reducing the burden of disease in narrowly defined conditions such as diabetes and obesity and hypertension and within individuals. Certainly as a physician, I've sent many patients home with very specific instructions to increase physical activity and eat healthy foods. But this slide reminds us that a true prevention strategy, as the National Prevention Strategy reflects, requires that you recognize and pay attention to all the determinants of health that influence the many choices that people have the opportunity to make in their environments, whether that's availability of fast food or safety of neighborhoods, access to spaces for play and physical activity, and of course the list goes on and on. Next slide. So again, although the list of social determinants of health is long, I want to provide a little background as to how we came to focus on the link between transportation and health. We know that inactivity is a strong independent risk factor, as Betsy has said, for chronic diseases, including overweight and obesity and diabetes, heart disease, stroke, hypertension, and certain cancers. And evidence is mounting to indicate that a strategy of increasing access to transportation options is associated also with increasing rates of physical activity. Next slide. So this is the challenge that we've observed here in North Carolina and across the nation. A transportation network that favors vehicles has contributed to a decline in more physically active modes of travel. In North Carolina, we found that less than 2% of our commuters walk, and far less than that even ride a bicycle. Nationwide, of course, there's been a significant reduction in children who walk or bike to school. And from our 2007 BRFSS, we noted that 60% of North Carolina adults would increase their physical activity if more accessible sidewalks or trails were available to them. Next slide. So again, we see similar links between health and land use decisions. The more facilities that are available in destinations that are close by, the more people walk. And people who live within walking distance of trails or parks or stores report higher walking than those who do not. Next slide. And of course, there's growing evidence regarding the health impacts of place, again, as Betsy has already described, and we know more about the impact of conditions that are found in neighborhoods and community and how they can affect physical activity. Again, next slide. So that's a summary of the background and the challenge that we were trying to address here. And so now I'll shift to the solutions that we're trying to implement here in North Carolina. Next slide. So we wanted to address the built environment, which is essentially everything that we design and construct in the places where we live, learn, earn, play, and pray. Next. Changes in the built environment require policy and environmental changes and actions at state, local, and federal levels. Here we're working to educate the public and stakeholders about policy interventions that impact health, and we're trying to create social and physical environments that make it easier to make healthier decisions. Next slide. So what have we done specifically at the state level, and how did we do it, you might ask? Next slide. I, of course, work within state government, and I have found in the time that I've been here that nothing in state government is easy or fast. So I really have to begin our story in 2006 when some important groundwork was laid for the work that we are continuing to do today. In 2006, the North Carolina Department of Health and Human Services, or DHHS, and I might add that is the State Department that houses our Division of Public Health. So DHHS convened a meeting of the State Departments of Transportation, Environment and Natural Resources, or DENR, and Commerce to discuss the possibility of the four agencies working together on common goals where public health, the natural environment, economic prosperity, and the built environment intersect. The result of this conversation was the development of the Healthy Environments Collaborative, or HEC. It's an interagency partnership whose mission is to integrate and align departmental efforts to improve the health of North Carolina's people, economy, and environment. When the HEC began meeting, partners focused on gaining an increased understanding of the work of each agency and the potential opportunities to work together to achieve common goals. Over the next couple of years, the HEC created a vision, a mission, a strategic plan, and gained support from the secretaries of the 4 state departments. In 2009, DHHS received Communities Putting Prevention to Work, or CPPW, funding through the American Reinvestment and Recovery Act to create more physical activities and opportunities for North Carolinians by creating environments that support physical activity. So with guidance from the University of North Carolina at Chapel Hill, Gillings School of Global Public Health, the HEC analyzed and prioritized the importance and feasibility of different activities that would support physical activity environments across the state. They also identified opportunities where they, as state agencies, could help remove obstacles that local governments face in their efforts to create physical activity environments. Next slide. The Sustainable Communities Task Force, or SCTF, is a more recent and expanded partnership among state agencies and other stakeholders that are working to support the integration of health considerations into community design. The Governor and the North Carolina General Assembly established the SCTF in July of 2010 in recognition of the need to use resources strategically to plan for and accommodate the rapid growth of the state given the economic challenges that we're facing here in North Carolina. The goal of the task force is healthy and equitable development that does not compromise natural systems or the needs of future generations of North Carolinians. To meet that goal, the task force is taking several steps, actually. First, it is educating professionals and the public on the practical benefits of sustainable community strategies and showing them how to integrate these strategies into their current efforts. Secondly, the task force is working to better align the decisions made by different agencies and by federal, state, and local governments. And lastly, it is building the capacity of local communities and regions to incorporate health benefits into the decision-making process for a range of development and infrastructure policies and investments. Membership in the task force is quite broad. It includes representatives from 6 state agencies, the Departments of Administration, Commerce, Environment and Natural Resources, Health and Human Services, Transportation, and the North Carolina Housing Finance Agency. The task force also includes representation from the building industry, the banking industry, a non-governmental organization, and city, county, and regional governments. The task force mirrors the federal Sustainable Communities Partnership between the U.S. Department of Transportation, the U.S. Department of Housing and Urban Development, and the U.S. Environmental Protection Agency. We believe North Carolina is the first state to enact a parallel program at the state level and begin implementation. The members of this group are also working with their respective federal counterparts and will serve as a conduit for lessons learned in other states, which can serve as resources for North Carolina communities seeking to become healthier. Next slide. As we stated earlier, we received CPPW funding in North Carolina, and the state-level partnerships, such as the HEC and the SCTF, made us more competitive for these funds and enabled us to be more efficient and get a higher return on investment by working across agencies. In addition to the work in the local communities that is noted on the slide, the CPPW funding allowed the state agencies in the HEC to work with 11 other communities across the state to assess policies and initiatives that influence access to physical activity at the local level. And the HEC obtained feedback from city planners and county commissioners, school administrators, and others. And before this work, health had not been considered integrally by those who set and implement policy for schools and parks and transportation and things like that on the local level. Now the Division of Public Health at the state level is an advocate for DOT's policies and initiatives like Complete Streets and vice versa. The agencies are able to show how there are transportation, environmental, and economic advantages to health being built intentionally into policy. Next slide. Again, there's a bit of a theme here. The state-level partnerships such as the HEC and the STTF also are enabling our work on the Community Transformation Grant. Now, as part of CTG, comprehensive planning for land use at state and local levels involves working to design communities in a way that considers protection of economic interest, air and water quality, health effects, and overall well-being. It requires a comprehensive approach to planning, designing, and building. And such community designs need to ensure that plans and policies do not disproportionately affect some segments of the population or inadvertently increase health disparities between populations. It also requires that public health professionals work together with various partners whose decisions affect community-level built environments. And these partners include, but are not limited to, the business community, school boards, elected officials, and environmental protection experts. Next slide. So we've talked about how partnerships and collaborations are increasing the consideration of health issues across governmental agencies. As another demonstration of that, I am pleased to report that in February of 2012, the Department of Transportation's mission was revised to include health. Their mission now reads, connecting people and places safely and efficiently with accountability and environmental sensitivity, and to enhance the economy, health, and well-being of North Carolina. The DOT recognizes that the opportunity to increase physical activity and therefore improve public health lies in the department's concept of active or healthy transportation. And they further recognize that active transportation is important to creating livable, vibrant, and healthy communities, and they are working actively to affect policy and organizational change that reflects that new mission. Next slide. Again, an example of that is under the direction of their current secretary, Secretary Conte, the North Carolina Department of Transportation has emphasized many initiatives that promote access to physical activity. One is the Complete Streets Initiative, and you can see the website address for more information about that initiative. And then secondly, another initiative that's promoting physical activity is the development of a statewide bicycle and pedestrian plan. This plan will integrate public health considerations and demonstrate how active transportation contributes to a healthier workforce that can increase worker productivity and enhance North Carolina's recruitment and retention of businesses. It also describes how biking and walking facilities can be co-located to provide enhanced access to conservation and green open space, as well as minimize overall impacts to the environment. And again, there's never been a comprehensive statewide bicycle and walking plan in the nation as wide-reaching as the one DOT is creating. As part of the plan's development, DOT is performing a health impact assessment to investigate and document the benefits of integrating bicycle and walking intentionally into transportation policies and practices. And the project is supported and funded by the Federal Highway Administration, Blue Cross Blue Shield, Commerce, Department of Environment and Natural Resources, DHHS, and others, and has become a bit of an unusual collaboration. So Transportation North Carolina is not just about cars anymore. Next slide. So in conclusion, moving forward, we hope to continue to expand opportunities to link efforts among different departments of state government and maintain our infrastructure for collaboration. And we would like to also participate in and further dialogue around linked funding streams from the federal level to address the built environment. We think that that would go a long way toward supporting and promoting such collaborative efforts. And of course, then the ultimate goal is that we're working toward is also health in all policy. And with that, I will end and thank you for your time and attention today.
Thank you, Dr. Gerald. We look forward to many more exciting things to come out of this work in North Carolina. Our final guest here to talk about an exemplary initiative is Dr. Allison Karpyn, who serves as the Director of Research and Evaluation for the Food Trust. Since 2002, Dr. Karpyn has led design and implementation of research and evaluation efforts for trust programs, and she's overseen the growth of the organization's external consulting initiatives. Her current research efforts include the study of farmers markets operating in underserved neighborhoods and the study of in-store marketing approaches in supermarkets to promote purchase and consumption of healthier options. In addition to her position at the Food Trust, Dr. Karpyn teaches at several universities and is certified as a professional researcher by the Marketing Research Association. Dr. Karpyn, last but certainly not least, you may begin.
Thanks very much. And again, thank you guys for having me. I'm certainly honored to speak alongside such a distinguished group. We can go ahead to the next slide, please. The Food Trust, next slide. Okay, thanks. The Food Trust began in 1992, and we actually began in a large indoor farmers market called the Reading Terminal Market that those of you familiar with Philadelphia will certainly know. Our mission is today, as it always was, to provide access to affordable, nutritious food for all people. And we do that through a variety of grassroots programs. We do advocacy work, evaluation and research, as you heard, and consulting to provide technical assistance and strategic support to government, other non-for-profit agencies, and also foundations. Next slide. I just realized that picture is my daughter's. That's pretty funny. The Food Trust, as I mentioned, was founded in 1992, and we work across the 5 program areas listed here. Farmers markets, we do school nutrition education work, healthy corner store work. I think we have the largest corner store initiative right now in the country at 628 stores. We do farm to school work. We're the regional coordinator in the Northeast. And then we work on supermarket, grocery store, and healthy food retail development work. And of course, a number of these initiatives are done in conjunction with our health department and our Commissioner Schwartz, who's been very supportive of these efforts in the city of Philadelphia. Today I'm going to focus largely on our work in the food and retail development sector and give you some updates on what's happening at the national, state, and local levels along the lines of a lot of our expansion work. Next slide. Our approach is really based on our successful campaign, which was launched in Philadelphia in 2001. And the campaign was really an effort to bring together key stakeholders, which ultimately resulted in the creation of the Pennsylvania Fresh Food Financing Initiative, which some of you may have heard of. It was the first of its kind, and it was a loan program that encouraged supermarket development in underserved neighborhoods throughout the state, which includes both rural and urban areas. Specifically, the state allocated $30 million for the effort, which then was leveraged by our partner, the Reinvestment Fund, which is a community development financial institution, or basically a bank that invests in communities. And they matched that 3-to-1 for a total investment of around $120 million. Next slide. So recognized by Harvard University as one of the nation's most innovative government programs, the Fresh Food Financing Initiative has provided funding for 88 now fresh food retail projects in 34 Pennsylvania counties and has created or preserved about 5,000 jobs and improved access to healthy food for more than 500,000 people. And about half of these projects, I should mention, are in rural counties of the state. Next slide. I mentioned briefly the job creation and workforce development benefits, but I just wanted to reiterate that this program not only created a tax base based on these stores, but also around 5,000 jobs. Next slide. And so as a result, the effort has really led to nationwide momentum. Nationally, 5 other cities or states have already launched financing programs akin to what Pennsylvania created. For example, in New Orleans, the Food Trust worked with Tulane University's Prevention Research Center and other local leaders to create the New Orleans Food Policy Advisory Committee. And in response to the committee's recommendations, the city created a fresh food retail incentive program that was seeded with $7 million. And then in March 2011, the city formally launched what is called the New Orleans Fresh Food Retailer Initiative, which, like in Pennsylvania, is a public-private partnership. And the program is administered by the Food Trust as well as Hope Enterprise Corporation, which is a local CDFI, Community Development Financial Institution. The initiative provides forgivable and interest-bearing loans to eligible applicants who plan to open or renovate grocery stores in low-income, underserved areas of Orleans Parish. And then in addition to the states that are listed here, there are a number of other states that are currently in the process of identifying strategies to alleviate the problem of food access. And many are working towards similar initiatives in terms of identifying funds that could serve as seed funds for stores. And the states that we're working with directly to support their efforts are Colorado, Massachusetts, Maryland, Mississippi, Georgia, Tennessee, Texas, Arizona, Ohio, and Minnesota. Next slide. In addition to the work going on at the state levels is the national effort called the Healthy Food Financing Initiative, and several have already spoken of the First Lady's emphasis on health and wellness and her commitment to solving the problem of childhood obesity within a generation. Access to healthy food is a key element of obesity prevention, as recommendations by the Institute of Medicine, the Centers for Disease Control, and the American Heart Association can attest. The Healthy Food Financing Initiative represents the first time that the federal government has coordinated efforts to eliminate food deserts around the country. And in a collaborative fashion, the effort is really a collaboration across departments, including the United States Department of Ag, the United States Department of Treasury, and HHS. Next slide, please. Generally, the initiative works to support the development of new or improved stores that sell fresh food, and it's focused on supporting neighborhoods of greatest need, including those with higher proportions of low-income residents. Next slide. As seen in the Pennsylvania program and other statewide efforts, the benefits of such a program include improving the public's health, creating quality jobs, stimulating economic development, revitalizing neighborhoods, and building market opportunities for farmers or ranchers. Next slide. A critical question that we're often asked is, what is a food desert or an underserved area? And there are several approaches to learning who's underserved in your community. I provided a link here to the Food Desert Locator, which was created by the United States Department of Agriculture. Nationally, cities and states have also relied on other national tools such as Policy Map, which is a product of the Reinvestment Fund, or maps developed privately by agencies that do work, mapping work on a consulting basis. Next slide. So as I noted earlier, the Healthy Food Financing Initiative is a collaboration across departments. And as such, funding has been allocated to the initiative from a few different places. In 2012, Treasury allocated, and there's an error on the slide, it's actually $25 million, not $22 million. And HHS allocated $10 million for a total investment of $32 million into the Healthy Food Financing Initiative. The request in the 2013 budget, as you can see here, is $285 million, which largely represents continued similar level of funding on behalf of Department of Treasury and HHS, but represents an increase in funding by increasing with a set-aside of $250 million from the $7 billion New Market Tax Credit Program. Next slide. So as I orient you to the next couple slides, I'll remind you that there are two types of organizations that are currently funding through the Healthy Food Financing Initiative, and that's the Treasury Department and HHS. So Treasury Treasury's funds have gone into a CDFI fund, a Community Development Financial Institution Fund, and HHS NPS funds, which I'll cover in a moment, have gone to the Community Economic Development Program. So I'm briefly going to discuss each of these. On this slide you can see that the CDFI fund looks at funding two different types of organizations. One is a CDFI, a bank like the Reinvestment Fund or Hope Enterprises, which I've already mentioned, or CDEs, which are designated community development entities. Next slide. So within this structure, CDFIs and CDEs are eligible to apply for and receive funds to support healthy food financing. And I've also provided links here to each of these programs if you would like more information. You can also see that 12 grantees in 9 states were awarded funds in 2011 on the CDFI arm of the funding program. Next slide. Listed here are those award recipients from the CDFI fund. I thought it would be useful for you to get a sense of where the funds are going and the total award amounts. And you can see that it crosses a variety of different states across the nation. Next slide. So then on the HHS side, the Community Economic Development Program has dispersed funds to community development corporations, the other CDC, right, and tribal or native organizations. Again, I provided a link if you're interested in learning more about the program. Next slide. A summary of the program is provided here, and basically these CDCs or Community Development Corporations are eligible to apply for up to $10 million in grants for a period of 3 to 5 years, and awards range from $125,000 to $800,000. Next slide. In total, 16 CDCs have been awarded funds from 11 states, including Alabama, California, Florida, New Mexico, Ohio, Pennsylvania, Rhode Island, South Carolina, and the other states listed here. Next slide. I thought it might also be useful to give you an example, a concrete example of a project that was funded with HHS HFFI funds. That's a lot of letters. The Butterfly Foundation is located in Spartanburg, South Carolina, as noted here, and it applied for about $500,000 to support a food hub idea. Food hubs are generally places where local farm product can be aggregated, sold, and value-added products could also be produced or sold as well. And the idea is that through a hub, local producers are able to tap into a viable market to sell their product either at wholesale or at retail. And then the dollars would be used in this program example largely for construction, with 23 jobs anticipated as a result. Next slide. This is another example of a case study. This is a little bit larger project where funds created a Republic Food Enterprise Center, which was a regional center that stimulated agricultural production and other value-added products. Next slide. These projects recognize the importance of partnerships across sectors, which has been a common thread from the Pennsylvania initiatives, which I began our presentation with, through the state efforts, and now across departments at the federal level. Next slide. I thought I would end today with a few resources that may be helpful for you as you learn more about this work. In this slide, the first 2 documents here speak to strategies for identifying funding sources from healthy food retail. Next slide. This is a link to the CDFI Fund Resource Bank, which provides a variety of resources on the funding side. Next slide. And last is a summary and tool section from the USDA's website, which also provides information about grant opportunities and frequently asked questions. I'm also, next slide. So I'll just end by saying that currently the Food Trust, PolicyLink, and the Reinvestment Fund are in the process of developing a web portal which will hopefully serve as a clearinghouse of information on the topic of food access. And we anticipate a launch early next year, so we hope that you keep your eyes out. Thank you again for having me. It's been my pleasure to speak with you all, and I welcome questions or comments.
Thank you so much, Dr. Karpyn. And with that, we've concluded the presentation segment of today's webinar. We'll now begin the Q&A session. As a reminder, you can submit a question for any one or all of our panelists. Just use the chat box that's located in your ReadyTalk panel. We'll take as many of our questions as we can and work with our guests to make sure that any unanswered questions are addressed and posted to the ASTHO and NACCHO websites, along with PowerPoints and any supporting materials. You can also join our newsletters by sending an email to either of the contacts listed on the last slide, which will advance here shortly, to hear about where and when these resources will be available on the web. So as we wait for the questions to roll in, we'll begin our Q&A with a question for Dr. Benjamin. Dr. Benjamin, you've traveled to many states and communities to raise awareness about the strategy. What about people's response to the National Prevention Strategy has surprised or encouraged you the most?
I guess all of it's been an encouragement. Everybody seems to be engaged. I guess the biggest thing is two things. One is just how much is going on already in the communities at the local levels and at the state level, so much on prevention, and having a national prevention strategy to pull it together and to kind of replicate it at the state level and the community, at the city and community levels has been really encouraging. Because there's so many people doing it piecemeal, and now to have a roadmap, if you will, has been really helpful. The other thing that's pleasantly surprising is how individuals are so committed and want to be healthy. And we talk to people, and they really want to be healthy for them and their families, and their hunger for that way to do it, and for us to make it easier for them to be healthy. For example, when we were in North Carolina, the first day, we were there 2 days, and so the first day the local media we talked about the fact that the next day we were going to have a walk in the evening and invited anyone to come. Over 200 people came out, almost 300 people came out at night. It was in the wintertime, so it was 6 o'clock in the evening. It was dark, and walked along this trail, and it was so much fun. But just people came out wanting to be healthy. And that's been encouraging, that we have a commitment from the individual on up. And so our role in government, both state, local, and national government, is to make it easier for people to be healthy.
Wonderful. Thank you so much, Dr. Benjamin. Ms. Pandora, I have a question for you as well. You spoke during your presentation about asking to be invited to the table. So in addition to what you've already shared with us during your presentation, what would you say is a common misperception that people have about the work that you do?
I think in specifically addressing being invited to the table, I think often if we hit as a health department or as the Healthy Places program some kind of roadblock, the misperception is that our expertise isn't new expertise, or that the health lens isn't necessarily a value-added lens for some reason. And so I think it's been our job to educate and inform why so much of this health and built environment work really is about prevention, and why it's not necessarily about a skill set or a set of expertise, but rather it's about applying the health lens as a form of prevention. So we won't necessarily recommend something all that different maybe, but because we've been invited to the table and because a health consideration has been made, an opportunity to address something that could potentially be missed, is there. I think that from the greatest misperception that we get from the private development community is that it isn't always necessarily their job to think of or pay for elements of design that support a healthy and active lifestyle. Often we sometimes get the viewpoint that that is the role of the public sector and not necessarily the private sector. And unfortunately, it's been the development patterns that we had in the past, where we didn't put in some really good active living infrastructure, supported an unhealthy lifestyle and has made, the epidemics and or the verge of epidemics that we see today an issue. So I think that, just making sure that you're always meeting whoever it is, either the public sector agency that you're starting a collaboration with for the first time or the private sector entity, where they're at sort of in terms of their process. Is it money that's their concern, or is it expertise that's their concern? And, educating with the health message has been very helpful.
Wonderful. That's a great answer. Would any of the other panelists like to comment on that question? And hearing none, we'll move right along. Dr. Karpyn, a question came in for you a little while ago. Can you briefly describe how your program works with or perhaps complements the efforts of the SNAP or WIC programs?
So in terms of the supermarket retail work, I think the connection is relatively apparent. We're looking to make sure that everyone in communities across America has access to affordable and nutritious food. And so we want to see retail establishments in neighborhoods that otherwise don't have places to purchase affordable food. And obviously SNAP and WIC also support that general vision. So we're looking to help consumers who are on WIC or purchasing items with SNAP to be able to go to retail locations to do that.
Wonderful. Thank you. The next question we have is for Dr. Benjamin. Any programs to combat drug trafficking across the borders?
Well, that's a good question. One of our members of our 17 agencies as part of us is the ONDCP, the Office of National Drug Control and Policy. They actually have a national drug strategy, and that's addressed in their national drug strategy, which we are part of, and it's part of the national prevention strategy. So you can go to their website and see the exact answers to that, but it's addressed in the national drug strategy.
Great, thank you. I have a question here that I believe is for all of our presenters here today. We have a question: how is the National Prevention Strategy leveraging lessons learned from the CDC's National Public Health Improvement Initiative practice stories? Would anyone care to share some advice on that question?
This is Dr. Benjamin. I don't really know the specific answers to that, but we can certainly get the answers, and we'll get CDC to give us some answers for that and put it on your website.
Great. Thank you, Dr. Benjamin. Ms. Pandora, a question for you. One of our participants says she loves the pedestrian walkways and the retail areas and the parking. The requirements are great, but who is responsible for financing these changes? And is there a grant or another funding mechanism available in your community to support this?
There's kind of two answers to that. In the instance of the rezoning example that I discussed, it becomes the private developer's responsibility to fund those things, and so that's why in many cases, it's great to have them put in when a project is happening, so that you're already spending money on a site and you can incorporate those things at that time. When we're talking about a much broader area maybe, we have a wonderful capital improvement planning process in our city where we've been very strategic through the capital improvement planning process to make sure that sidewalks and bike infrastructure and other amenities that support active living are considered within the capital improvement plan and addressed, sometimes addressed at a neighborhood level, sometimes addressed at a spot improvement level. Something that we've been very fortunate to have, kind of dovetailing off of something that was talked about in North Carolina, is we did a citywide bikeway plan in 2008 that we adopted in 2008. So through our capital improvement planning and funding process, we're actually able to, on a piecemeal basis, construct a bikeway network that is really helping to connect a system of bikeways and bike facilities across our city.
Thank you. Dr. Gerald, I have a question for you. During Ms. Pandora's presentation, she spoke to the importance of having a vision reflected at the state and local levels. Dr. Gerald, I wonder if you can talk about how the leadership at the state and local health departments is important for the sustainability and the continued success of collaborations such as what you've described in North Carolina.
Well, thank you for the question. I think that all of us as presenters have emphasized how important it can be to have both champions and conveners. And I think that that is one of the roles we tend to play within public health at both the state and local levels, is that we often are the impetus and catalyst for trying to encourage both our state and local partners to put health in all policies. And so it is often that role of state and local health department leaders that can start those conversations and start those relationships. I think that one of the things we reiterated in our example of how we formed collaborations with the other state agencies and departments, all of these things started with people, individuals talking to one another and getting to form relationships and friendships and opportunities to speak to each other, and those relationships often then translate into policies and getting some of our health concerns into policies.
Terrific, thank you. We had a question that came in a little while ago that I wonder if all of our panelists could comment on. Ray Lewis wants to know, what is a good resource to find out what is going on in my state? Are there any resources out there to all of our panelists that you might recommend for someone who is interested in knowing what is going on in his or her state?
This is Dr. Benjamin. There is a website, communitycommons.org, and we've been posting things that are going on in the various communities, and you can look up your community by zip code, is it? And some of the cities that we've already visited will have icons there that you can just click on, but you can look up your city and to see, or your community to see what's going on there. Communitycommons.org. Communitycommons.org.
This is Dr. Gerald. I would also expect that in most states, as is true in North Carolina, your state division or Department of Health or Public Health would also be a good place for resources, because oftentimes, like on our websites, we can link you back even to your community-based resources, whether that's your health department or other things that are located in local communities, and give you a sense and a broad sense of what's going on across your state as well.
Thank you for that. Go ahead, Ms. Pandora.
Sure. I think from Columbus's perspective, and this is a local person trying to figure out what people are doing in other localities, we often tend to collaborate and work with our metropolitan planning organizations quite a bit because they tend to be really well linked in regional chunks and spend a lot of time allocating dollars for transportation projects, but also thinking about other things like food access and housing that also play a major role in what is going on in terms of built environment projects. So I would probably plug in with metropolitan planning organizations.
Excellent, thank you.
Sorry, this is just Allison. I just wanted to say that this is a question that I smiled when we got, because it's one of the things we realized as we decided to launch a web portal idea for food access, that it can be tough to figure out what's going on in your state or city when it comes to food access projects. And so hopefully in the new year there'll be a place to go when it comes to food access on the web portal.
Great. Thank you to all of our panelists for taking on that question. Another question for all of our panelists here today Do you see any role for health information technology in your work? And once again, this is a question for all of our panelists if they would care to address the question about health information technology.
Well, this is Dr. Benjamin. I'll just kind of start off with some general things. I guess the first part of the year, we had a apps challenge, basically to find the best apps to work with people to become healthier. So part of it was a physical fitness portion like exercise. Another one was for food. And another one was for integrative health. Did you get enough sleep at night? What's your stress level? Using those apps just to help and follow your progress. And we've been using the winners of those and working with those. And that's been a lot of fun. We've also had a video challenge for the tobacco report where the youth made videos that are posted on YouTube, and the winners are there, and so are the other videos that are really quite creative and quite fun that the young people themselves have created. So we've been trying to find innovative ways to use technology to bring health to where people are, just right there. We're also work with Facebook with a suicide project to identify people who may have suicidal comments in their Facebook pages. That's been going on for about a year now. And so we're trying to use technology in innovative ways.
Great, thank you. Would anyone else like to comment?
This is Dr. Gerald, the State Health Director for North Carolina. For us, a lot of our health information technology efforts are in the field of health information exchange, and we are in possession, in public health, of a lot of information that speaks to disease burden and different levels of disease, whether that information is coming from our hospital ED surveillance systems or our communicable disease surveillance systems or our behavioral risk factor surveys and things like that. So we have a lot of bits of information that we can then feed into an HIE or an HIT system, and I would hope in terms of impacting our efforts that as we increase the amount of information and surveillance data that we have available to us, that we're then able to use, real-time changes and increases or so that we may see across different diseases to help us in our prevention efforts. Hopefully, HIT will help us to be more timely in our information gathering and sharing, and then will subsequently let us tailor our prevention efforts accordingly.
This is Dr. Benjamin again. There's also a program, several cities around the country, but Detroit's the one that comes to mind because it's where I was there, and it's a program called Text for Health, and basically it's similar to Text for Babies, but this, what do they call it? The program is Fighting D and the D, Fighting Diabetes in Detroit, and that program basically, you send a text message or you sign up for it and you'll get a text message every so often, every few days, about things like exercising, coupons to where at local grocery stores to buy healthy things, and inspirational type encouragements. And the Text for Health has been going on now since the late spring.
Thank you, Dr. Benjamin. And we have a few minutes left today during the webinar, so any final questions or comments that you'd like to submit, please do so at this time. And Dr. Benjamin, just to wrap up here, given that we're here today to recognize the first year of the National Prevention Strategy in action, we were wondering what or how you would describe success in 1 year from now.
Well, our goal, as you know, is to increase the number of people who are healthy at every stage of life. And so we've been using the Healthy People 2020 goals and objectives to be our goals, I guess, to measure. But from year to year, one of the things we're trying to use is the health rankings, and using the health rankings that come out once a year to see if we've moved that needle at all. And hopefully some of the things that we can see within a year, like decrease the amount of smoking in your community, increase the number of people who say their health is improved or health is good. Those health rankings come out around, I guess, December or January each year. And so we hope to see those move into a positive place and increase the number of people who are healthy, and that's our goal.
And that's certainly a great goal and a great aspiration. So no more questions have rolled in, so I think we'll conclude today's webinar here and give you just a few moments back in your day. We sincerely thank each of our panelists for their participation today and for their ongoing leadership. The first year of the National Prevention Strategy has really seen a new wave of collaboration, and we're hopeful here at ASTHO and NACCHO, as many of you are, that together we'll continue to find ways to strengthen prevention and create conditions for health in each of our states and communities.
And Leslie,
so
can I just add that I want to thank all of you for your help and the fact that we are starting to move the way we think about health in this country, that people are thinking about it in everything they're doing, and we need to continue that. And I hope that the National Prevention Strategy will help serve you in your states and in your communities, and hopefully you can start to replicate those on a city and state levels. Thank you very much.
Thank you, Dr. Benjamin. And if there are no final thoughts or comments from the rest of our presenters today, we will conclude today's session.
Ladies and gentlemen, that does conclude the webinar for today. We thank you for your participation and ask that you please disconnect your line.